The following program contains views and opinions which are not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birenbaum.
Good afternoon, everybody. This is Cancer Update, a short walk through a very long journey. The phone number here at KAAM 770 on your AM dial is 972-445-0770, and the toll-free number is 877-272-5226. Please call in with any question that you may have. I represent Texas Hematology Oncology. Our office number is 469-453-5500. I want to start today's show with something that just recently came out in the ASCO. ASCO is ASCO, American Society for Clinical Oncology, their newsletter, talking about the top 5 lists in oncology and how to structure it in order to take care of cancer patients. Their number one recommendation for cancer patients is those patients with advanced solid tumors. Let's understand what solid tumors are. There are really 3 types of cancers. At one end of the spectrum, there's liquid cancer. That's like leukemia. At the other end of the spectrum, there's solid tumor cancers. That's lung cancer, breast cancer, stomach cancer, colon cancer, bladder, ovarian. And in between are the semi-liquid and the semi-solid cancers, the melanomas, the lymphomas, the sarcomas. So they're talking in this recommendation from ASCO, put out by various professors, Dr. Michael P. Link, who's the president of the American Society of Clinical Oncology, and this was taken up of a survey of multiple oncologists from throughout the United States. They state that for patients with advanced solid tumor cancers who are unlikely to benefit, avoid unnecessary anti-cancer therapy and focus on symptom relief and palliative care instead. Those patients who have either not responded or in whom there is not a protocol that leads them to a significant disease-free interval or survival time that is worthwhile, they recommend to treat the symptoms and for palliative care. The idea, they show that there was not any significance in the number of cancer patients who received chemotherapy in the last 2 to 4 weeks of life. Such treatment does little to improve the quality of life, nor does it have any benefit on tumor response. They recommend eliminating treatment that is unlikely to be effective in patients who meet all of these criteria and with low performance status. Number 2, deals with staging of patients. When we talk about staging of patients, we're talking about getting the appropriate studies, x-rays, laboratory tests, and tumor markers. They recommend not to use the PET scan, the CAT scan, and the bone scan in the staging of very early solid tumors, especially breast cancer, that have statistically a low risk of spreading. Now, you'll find this to be very controversial because most oncologists that I know, and where I was trained at MD Anderson, you always want to get a baseline protocol, a baseline study done on the patient to have, because everything in oncology is based on comparison. So I don't know if I would eliminate doing all types of preoperative or pre-treatment studies. Most of these patients they're talking about is somebody in breast cancer who will have just either a lumpectomy or will just have surgery and do not require any radiation therapy, do not require any other further chemotherapy. They may, depending if they are estrogen and progesterone receptor positive, if they are placed on some type of anti-hormonal therapy, again, you're putting them on some type of therapy. I think they need a baseline evaluation done in order to discern whether or not for comparison later on. Number 3, they recommend not, and I repeat, not using the PET scan, the CAT scan, or the bone scan, again, in early prostate cancer, because it is at a low risk of spreading. So if you have somebody that has a very low Gleason number, and that's the number that the urologist will provide after doing the biopsy, and they show no evidence of lymph node involvement, and they show no evidence of invasive component, they do not recommend doing any type of preliminary x-rays and evaluation. Again, I can tell you that most of the oncologists that I deal with, both in breast cancer and in prostate cancer, other than getting the preliminary blood tumor markers, they will get some form of a baseline study. In the prostate cancer, probably the only study that I would recommend would be a MRI of the pelvis to evaluate the contiguous area around the prostate gland. Number 4, for individuals who have completed curative breast cancer treatment, who are totally asymptomatic, routine blood tests for tumor markers and advanced imaging should not be used unless the patient is symptomatic or shows any evidence of symptoms whatsoever. I would tend to agree with this, but remember, these are patients who, as it says, have completed curative breast cancer treatment. That means they've been on some form of treatment, be it chemotherapy or radiation therapy. And I think some period of time they need a follow-up, minimal or partial staging workup, and follow up on their tumor markers. Now, if you do this at 6 to 9 months and all the studies are negative, then I would probably not do it again for at least another year unless the patient becomes symptomatic. And the last thing they recommend, and some of you don't know what this drug is, it's called Neupogen. Neupogen is a drug in layman terms that will help stimulate the white cells to prevent infection. They recommend avoiding the administration of white cell stimulating factors to patients undergoing chemotherapy who have less than a 20% risk for febrile neutropenia. Neutropenia is a low white count. A lot of patients who drop their white count will develop feverish episodes, and then you need to probably draw cultures on them, urine and blood cultures, and place them on some form of prophylactic antibiotics. So there's growing evidence that these drugs, principally the Neupogen drugs, are overused, and they are very, very costly drugs. But if you have a patient who is undergoing systemic, meaning IV chemotherapy, and they have evidence of neutropenia, I think then that you owe it to your patient and you owe it to yourself in order to manage them correctly and make sure that they don't come down with a fulminant septic infection and have to be placed in the hospital when, had it been taken care of in the first place, you could probably treat them with oral antibiotic therapy. We've just been entered as Tina Withrow, our patient navigator. Tina?
Good afternoon, everybody. Sorry I was a little late. That traffic always gets us once in a while. Hope everybody's having a good week, enjoying the weather. I've once again got some questions for Dr. Birenbaum from patients and from cancer survivors. One of the questions I had from someone was myelodysplastic syndrome. Could you please explain what myelodysplastic syndrome is, and does it always lead to a cancer diagnosis?
We'll go forward and then backwards. Forward, there are many patients who have never, ever been on any form of therapy, any form of chemotherapy, radiation therapy, immunotherapy, any therapy at all. And as they have gotten older, and it mostly occurs after age 60, 65, their bone marrow is not reproducing at a normal rate, and their reproductive precursor cells, the white cells and the platelets and the red cells, are just not producing. And gradually they develop anemia, low hemoglobin, thrombocytopenia, low platelets, and leukopenia, low white cells. Sometimes it just stays at a chronic level. Nothing needs to be done. You do all the appropriate studies. You even do a bone marrow aspiration biopsy, and you find that their cytogenetics and their flow cytometry and everything is okay. And over time, it gradually deteriorates, and they develop a myelodysplasia, and meaning myelo blood cells, dysplasia, inability to produce. The cells become dysplastic. Now, in my experience, the most common time that I have seen this, and again, these patients can eventually convert over to an blastic phase of leukemia, a chronic myelogenous leukemia. But you go in the other direction, in my experience, a lot of patients who have been on some form of chemotherapy, some form of radiation therapy, especially if they've had radiation to the broad bone areas, principally the hips and the pelvic area, which is one of the large producers of your bone marrow, and the long bones, principally the femurs. They've had radiation to this in conjunction or concomitantly with chemotherapy. Over a long period of time, they will have continual suppression of their marrow, and they develop a myelodysplastic type of bone marrow. Now, these have a greater chance because there is a chromosome abnormality that goes along with this, both in the non-chemotherapy related and in the regular myelodysplastic syndrome. There are some drugs out there, Dacogen and Vidasa. These are two drugs that are given 5 days a week, 1 week out of every month, and they will hopefully prevent the counts from going too low. And with the aid of Procrit for red cells and Neupogen for white cells, help regenerate the bone marrow. In general, most myelodysplastic patients, unfortunately, the primary treatment is transfusions. They sometimes need every 2 weeks, and as it gets worse, you may see them twice a week in the hospital getting red blood cell, packed cell transfusions, or getting apheres platelet transfusions because they're having a lot of purpura and ecchymosis and bleeding. What's purpura? Purpura is like a purple bluish bruising of the arms or the extremities. Petechiae are little red dots that are due to low platelet counts. They turn up usually on the lower extremities more than on the lower part of the abdomen, but mostly on the lower extremities. And these are an indication that your platelet count is also suppressed.
What's the other thing you said? You called it something, apapora or something like that? You said petechiae, purpura,
ecchymosis. Ecchymosis is the bruising.
Okay. You know, you got to bring it down to us girls level. You know, what are we supposed to do? I wonder if he can spell all of these words that he's talking about. Another question: lymphoma. A lot of times, patients will have lymphoma. They'll have tumors in their chest. Correct?
Enlarged lymph nodes. Yeah.
Okay, so that just answered my question, because if lymphoma is a blood disorder or classified as a blood disorder...
No, it's really, before you got here, we classified liquid tumors, leukemia, solid tumors like breast, colon, prostate, and the semi-liquid or the semi-solid tumors are your melanomas, lymphomas, sarcomas. It's a soft tissue type of tumor in generalities, but it is I would call it a mass tumor. It affects lymphoma is basically a cancer of the lymph glands.
I received some information from Leukemia Lymphoma Society, and we've sponsored them in a big way over the years. And I love to be able to direct patients to them and to help patients with them.
It's an excellent organization.
It really is, and they're one of the few organizations that are able to help the patients with the day-to-day financial impact of cancer. And I believe that we send a lot of our money for dollars, and Stand Up to Cancer is a great organization, but I really think we fall very short on helping people today diagnosed with cancer. So I met with them, and we were talking, and they left me some information. I just kind of wanted to give you all some facts out there. And these are 2011. In Texas, there will be 3,280 people diagnosed, or that were diagnosed last year, of leukemia. And then non-Hodgkin's lymphoma, 4,520. This is in the state of Texas. Myeloma, 1,550. And Hodgkin's lymphoma, 670. So
that's all of Hodgkin's?
That's
670?
New cases.
I would have thought there'd been more than that.
I did too. So then cancer deaths, 1,410 leukemia. That seems high to me. But is that just because a lot of times people are older and there's some other comorbidities, they have other problems?
A lot of times patients go on, like you said, with comorbidities. The definition of comorbidities means that you have heart disease, diabetes, arthritis, rheumatoid arthritis, colitis, diverticulitis. You have a multitude of diseases. So you have a lot of comorbidities, and you always have to worry about comorbidities when you're giving radiation or chemotherapy. And a lot of times they come down with an abnormal blood count, and no disparaging comment on any family practitioner, but they look at it as part of the comorbidities as being a chronic anemia, when really it could be an onset of an early form of adult leukemia. Now, the most common type of adult leukemia is CLL, chronic lymphocytic leukemia. I call it the good guy because it's really easy to treat, and patients live a long time with CLL. A lot of times they never die from their CLL. Then the other most common type you see is chronic myelogenous leukemia, and today that's really easily treated with Gleevec, and patients do real well. However, if they go into a blastic transformation, or if they go into some form of proliferation, then we come.
What does that mean, proliferation? I'm sorry to keep
further spreading and further worsening of their bone marrow, further worsening of their condition. Then we get into the big political discussion, and it depends on where you're trained and where you come from and how aggressive you are. That's where you get to the point at what age is the right age. There are some places that say 70 years of age is the cutoff age, or 75 years of age is the cutoff age for a bone marrow or a stem cell transplant. I don't look at it that way, and fortunately where I was trained, they don't look at it that way either. What's more important is the performance status of the patient, the comorbidities of the patient, the overall condition of the patient, in order to determine whether or not they are a candidate for a transplant.
I want to give you just a statistic, a comparative statistics. I gave you the numbers. My home state is Ohio, and 3,280 new cases of leukemia in Texas. 1,690, but then when you look at the death rates in Ohio, it's 900, and then in Texas 1,200. That really tells me that there's something happening better in Texas than Ohio, if you think about that.
Well, I think it gets down to who's taking care of you and how aggressive they are.
Well, I could tell you that from how my family was treated. Not anything against Ohio. I just think you can get better treatment for cancer in the great state of Texas. That's for sure. Answer me this question, Dr. B. This is regarding ovarian cancer. I had somebody talk with me this week about ovarian cancer, and they just presented that they all of a sudden started having trouble breathing. They just kind of felt a heaviness. And before they knew it, they were having trouble breathing and presented to the hospital. And they said stage 4 ovarian cancer, and they're going to treat her with chemotherapy, then surgery, and then I'm assuming chemotherapy, radiation. Is that often how you find a late stage ovarian cancer, that somebody's really had no symptoms and then all of a sudden just boom, that's what happens? One
of the common presentations in a silent ovarian cancer is that the patient all of a sudden will start getting ascites, fluid in their belly, and that a fluid will accumulate. And as it accumulates, it pushes the diaphragm up. And when it pushes the diaphragm up, you get a restricted vital capacity. You can't take a deep breath. You don't have the breathing capacity because you have all this fluid in your belly pushing the diaphragm up, and it shortens the lung capacity. Therefore, you get more and more short of breath, and that's how your initial presentation is. They'll go in and they'll do maybe a paracentesis to relieve the fluid in the belly, and they realize that there may be a mass or whatever it is. They find out she's got ovarian cancer. And the treatment obviously is to debulk or reduce the size or remove all evidence of tumor. And in the hands of a really good surgeon, they'll be able to go in there and remove the ovarian mass, do adequate sampling and dissection of all suspicious lymph nodes and any other masses that are present, remove all the acidic fluid, and then treat her. Sometimes you're not able. Some of the standard protocol would be to give neoadjuvant therapy, give chemo first, then surgery, then more chemo. But if a patient presents with these kind of symptoms, you've got to take them to surgery to, one, improve their quality of life and to remove as much tumor burden as you can. And then afterwards, you'll put them on appropriate chemotherapy. Usually it's going to either be with a platinum base or an anthracycline base. One of the common drugs is adriamycin or Doxil, or a cisplatin or carboplatin chemotherapy.
Another question that I had, another comment. I saw a program called New York Med. I don't know if you've seen it. It's by Dr. Oz, and if Dr. Oz says it, it must be true. He's my guru. He's everybody's guru, and everybody thinks he's really cute also. But anyways, seriously, they showed a woman with a liver cancer, and they actually removed the whole liver.
Was it a primary liver tumor, a hepatoma, or was it a metastatic cancer from the colon that went to the liver?
It was not a secondary.
So it's a primary liver hepatoma, hepatocellular.
And they actually removed the whole liver. Said it was they said they'd not done that very often. Removed the whole liver. They showed it. They took it completely out of the body and set it, and then turned it all over or whatever.
Did a transplant?
No, they put the liver back in the body.
The same liver?
The same liver back in the body. And
what did they do with it in between? Take it to the laundromat and clean it?
They did whatever, but they said it was very remarkable because it was the first time that they actually ever had removed a liver from a person, removed the cancerous part, and then put the liver back in. And I thought, wanted to ask, is this...
I honestly have never heard of that done.
Yeah.
I have many times heard in a hepatoma, which can be treated with oral Nexavar tablets.
What does hepatoma mean?
Hepatocellular liver cancer.
Oh, okay.
It's called a hepatocellular carcinoma, or a short name is a hepatoma. Basically, for layman, it's a primary cancer of the liver. It is not a cancer like lung or breast or colon or any other organ that has spread to the liver. That's a secondary liver cancer, and you treat that by treating the primary. If it's a colon to the liver, you treat it with fulfoxamide. You don't treat it with the drugs that you treat primary liver with. What I have heard is for them to go in and do a arterial embolization, where they embolize the artery to the liver and then resect or remove either part, half. I've even seen them resect the entire liver and do a liver transplant. There are 2 institutions here that I know of. There may be more. I know Baylor Medical Center in Dallas has an outstanding liver transplant center, and Methodist Hospital. I've used them personally on a couple hepatoma patients who underwent partial hepatectomy. Meaning partial removal of their liver. They did the surgery. They didn't do a transplant. I have had one transplant over at Methodist as well. So you have two outstanding liver programs that are nationally known here in the Dallas area. There may be some in Fort Worth or elsewhere. I don't know. I'm just saying Methodist over on Colorado in Oak Cliff and BUMC downtown Dallas Medical Center are excellent liver programs. And I've seen liver transplants for hepatomas, but I've never seen them remove the liver, wash it out, and whatever they did, and put it back in.
I'll have to get you the documentation
That
on
I've
it.
never seen.
Because you
Never
probably will think I was watching some cheesy wrestling channel or something, but I really did see it, and I know a lot of people.
Well, there's no telling what you watch if Dr. Oz is your idol, but that's okay.
Well, I watch Dog the Bounty Hunter if you want to know the truth, but that's another whole story.
All right, we're going to take a short break here on Cancer Update, short walk through a long journey. Please call in at 972-445-0770.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. This is Cancer Update, a short walk through a long journey. The phone number here at KAAM Radio, 770 AM on your dial, is 972-445-0770. I'm here with Tina Withrow, our patient navigator. I want to just bring up some data that has recently come out. They talked about in colorectal cancer in The Lancet, July 2012, in the preoperative chemoradiotherapy and postoperative chemotherapy treatment with what we have told you before on the channel as full FOX, that's 5FU, and oxaliplatinum. They showed that by including oxaliplatinum into the modified 5FU combined modality treatment was not only feasible, but led to more patients achieving a pathological complete response than standard treatment with just 5FU leucovorin by itself. The longer follow-up showed that there was an enormous improvement in the disease-free survival of the patient. And these are things that we want to bring up to everybody in the audience if they or their friends are come down with some of these horrible diseases, that there are protocols out there that are beneficial, that have excellent results. There is a new drug. Somebody comes down with lung cancer. There's a new test out there. It's called the ALK, A-L-K. So you need to ask your doctor whether your ALK on the pathology was positive. If it was positive for non-small cell lung cancer, which is the most common type of lung cancer, there are 2 drugs. One we know about, that's called Alimta. That's a very common drug used in chemotherapy for non-small cell lung cancer. But in those patients that are ALK, A-L-K positive, there's a new drug called, I'll spell it for you, it's Xalkori, Xalkori. And by administering this drug, it improves survival anywhere from 20 to 22%. So another item that is out there, new things coming in the treatment of cancer. And the last I want to tell you about is a new drug. It's not really new, but it's new for this disease. People who come down with gastric cancer, there's a new drug, Afinitor, are everolimus, Everolimus, or Afinitor, usually has been used in the past in kidney cancer, renal cell carcinoma. But like many of these drugs, they try them out in other diseases. Like Avastin was initially brought to the community, been shown to be very effective in metastatic colorectal cancer. It's now approved for non-small cell lung cancer, ovarian cancer. It's controversial in the use of breast cancer, but now they're showing that Avastin is also effective in melanomas, and it's just like this drug Afinitor. Afinitor initially came out as being very effective in kidney cancer, and now they're using it in some forms of melanoma, and now the studies have come out showing that this ongoing biomarker identifies good responsiveness in the subgroup of gastric cancer patients in helping improve survival and disease-free interval. So just some information for you that you can pass on. There's a lot of new things coming out there in the field of oncology. I think the most important thing to me, I go back from when we first started this show, the most important thing is early detection. Remember one thing, the smaller your tumor burden, the smaller the volume of tumor, the smaller the mass that you may have, be it breast cancer or an early colon cancer or even an early prostate cancer, the earlier you can get that detection, the earlier you can go in and get that screening, the longer the survival.
Dr. B, I'm about to talk to you about a story that I want your opinion, and I know it's going to be controversial, and HIPAA. You know, we've talked about HIPAA, and HIPAA's something that's here to stay. And, you know, I've always shared with patients, you've always had a, good policy as far as, what's required before you release information for patients. And there's some things that you just have no control over. Patient's going to come in the office. If they're part of the practice, they're going to overhear you talking about somebody else's protected health information. I mean, we warn them of that ahead of time. If you put too much restraints on it, then you can't do your job. I can't do my job, and I understand that. Very alarmed last night. I always record the evening news although after last night and the stuff that's happening in the world, I've made a decision I'm not going to watch the news, especially since my son is in Afghanistan. But anyways, they talked about people being able to purchase your medical records off the internet. And they showed a man who went to an open cafe in New York City and was able to obtain people's protected health information. And then they profiled a man, just a working man, and they went up to him and interviewed him and said, "Did you know that I was able to get all of your health information out there?"
I thought to get into the medical records, like for me, when I go to the hospital to do my charts, to do my medical records, I have to put in my code. And I punch that in. Well, I have somebody else do it because I don't know anything about computers. So somebody does that for me. They punch in my code number, and it pulls up my medical records. Mm-hmm. So how can somebody go to a cafe?
What they're saying is that the walls
without a code.
What they're saying is the firewalls, the block walls that make it, there should be different firewalls that keep you from getting past a certain information that with hospitals and physicians' offices are not very good, as good as they thought. And what they're concerned about is that people are using this and they're becoming more and more sophisticated. And what they're being able to do is break into computer programs. And I really thought it would never happen, but they're doing it for the purpose of billing. They're just taking these people's information and they can see. They said there's a variety of reasons that they do it.
What do you mean billing?
What
are they billing for?
Well, they're just doing illegal billing. But the other thing they're saying is that companies are offering large amounts of dollars to, let's say, a nurse in charge of a diabetes endocrinologist's office, or, and that way a company that wants to market diabetes products, if the nurse can get them all the information or feed them that kind of information, then that's very valuable. So there's this whole underground network going on, and I never thought it would. I mean, I've always told people your information is protected. I feel pretty strongly that it is in our office. I've not had any problem with that, but I just wanted to know what your thought is on that we could be facing something like that.
Well, number one, it's invasion of privacy, most important. Number two, health information records, unless they're going to be used for some sinister method, sinister concept, like you mentioned, doing false billing. Unfortunately, I would say the vast majority of patients rarely look at their EOBs. They don't check their bills. They don't know if John Doe sent them a bill or XYZ sent them a bill. It just goes through the insurance company, because this false billing individual or company or cohort is not asking them for a copay. They're not asking them to make up the 20%. They just want to get the money from the insurance company. And if you got a $100 bill and the insurance paying $60 and the copay is another $10, throw away the 10, give me the 60. And they can do that on 1,000 or 2,000 patients. It's a hell of a way to make money. But I cannot fathom that. I guess, I'm just naive. People are out there doing that and just stealing people's files.
It just shocked me.
I would be more interested, now that they're doing away with pre-existing illness, and insurance companies have to cover you even with pre-existing, getting somebody's files doesn't seem that much important anymore. It used to be you filed for health insurance and everybody lied on their policy. No, I never had an illness, or I never had this, or I never had that. And the insurance representative had to take you at your word. And now, or they could go try and find some files, and that's where I thought the HIPAA violation would come in, where you steal somebody's files and sell them to the insurance company, and the insurance company would then have that information because they're in the business of making money. But with the new advent of no pre-existing illness, I don't know why somebody would want to sell somebody's files other than marketing. Like you said, you get all this doctor's offices, he's an endocrinologist and has 1,000 diabetics, and you want to sell paraphernalia or apparatus for diabetic patients. This is a good source of marketing for them, but it's very scary. I think kind of comical. If you remember the gentleman, we talked about this one time, who bought the New Jersey Nets basketball team. He's from Russia. He used to be in the Secret Service there in Russia. And he is the primary owner, and he allows no computers in his office. He doesn't even have a computer. He's afraid of getting hacked. He's afraid of somebody getting his information off his computer. This shows you the exact example of what you're talking about, people getting in and getting your
I was
medical
shocked.
files.
I was just shocked. I just didn't think it would happen. There's also something so that the public knows that's changing, and it's part of the Obama plan. It's part of, I call it the Obama plan, but it's really part of what the government, Republican or Democrat, it's how they're all changing how we access medical records. And it's something called meaningful use, not politically motivated. But meaningful use means physicians' offices will be penalized with reduction in payment if they do not start to use meaningful use. And meaningful use is to have electronic health record, not only that keeps your electronic health information on a computer to supposedly reduce paper, but you also are going to have meaningful use is having your patients interact on a computer system with how are they feeling, what are their drugs that they're on, and all of this in-depth thing on a computer. And my only thing about that is, if you're going to penalize a physician, what about the physician that has an overabundance of elderly population that doesn't want to use a computer, is too sick to use a computer? I think the system can end up being a little bit flawed. On Tuesday evening, I had my support group, and I have a hospital administrator that's very active in that support group. And the questions that I asked, she said, she was very honest. She said, I don't know that meaningful use, I don't know how it can be measured. She said, I think it's really terrible that we're going to penalize physicians for this when really their demographic mix may not be able to complete what it is. Again, some really good things have come out of electronic health records. I do support some of it, but some of it I think can be very flawed.
What happens in the scenario that you just presented to the doctor-patient hands-on relationship?
Oh,
I mean, if you're talking to a patient by computer, he's telling you their symptoms, and you need to examine the patient for any enlarged lymph nodes, or you want to listen to their heart. There seems to be something lacking here in medicine.
I think there's a shift. I think it's a shift. I think you touched on it.
It sounds like you might as well, every office can go ahead and have about 5 or 6 PAs, and the PAs are going to run your office. The lack of the doctor-patient relationship, I think, is a travesty to medicine. It takes away from what the purpose of medicine is, I think.
I think it's a very good point that you bring out, that we've just got to really being, really, really careful.
I had a woman today in the office that I'm treating for low platelet count, and she is new here, has a beautiful British accent, great to talk to, a lot of fun. And she just told me she doesn't have a private doctor. She needs a family doctor because, I do hematology oncology. And she was very blunt about it. She said, number one, I want to have a doctor. I don't want to have a PA. I want to have a doctor that's accessible to me. I don't care if I have to pay, even though I'm Medicare and a secondary. I just want to make sure I have a doctor and that I'm not sent to an MA or PA or some secondary person. I want to make sure I have a doctor that I can go talk to and that's available. I found that interesting because it's been a long time since I had a patient tell me what they demand that they want to have. I usually refer them to, if they need a family practitioner, I've got a list about, I first find out where they live and what is convenient to them. And then, she lives in the Farmers Branch area, so I would use a doctor either that is accessible to Dallas Medical Center or Baylor Carrollton, and in the Farmers Branch, Carrollton, Addison area. And so I have a list of family practitioners in that area, and I may even include Presbyterian Plano may be included in that area. But I just found it interesting that she was just very forthright and blunt about it. She says, I've gone to too many doctors' offices, and I call the office, and I end up talking and spending my money on a PA or an MA, and I never see the doctor.
Well, and I think that PAs have their place, but I think the physician is still the primary quarterback.
I cannot, and I know this is contrary to probably the norm in the Dallas-Fort Worth area, and I've never been part of the norm, but I could not see being an oncologist, forget GP or internist. I could not be, I think, a good oncologist, a thorough oncologist, if I let somebody else manage my patient who did not have a medical degree. I don't mind a PA helping me seeing patients or working the charts, but I cannot see a PA answering the phone calls and the problems of the patient when they just don't have the background foundation in oncology that an oncologist would have.
Very good. Something else I got an email from someone who just asked me to describe what a patient navigator is and does. So I thought this came out of the Leukemia Lymphoma Society. So I'm just going to read you what their quote is on what a patient navigator is. A patient navigator is an expert who can lead you through the maze of insurance as well as many other challenges in the healthcare system.
Stop.
What's that?
Stop. You are about the best I've ever seen at that.
Well, thank you.
And I think part of that is because of your background in the insurance business. I think any patient navigator out there, and I don't know about patient navigators at other institutions, but I will tell you this, I think one of the great benefits that you have over any other patient navigator I've seen is your background in insurance, that you're able to literally, let's use the word navigate, but I think you take them in the hand, by the hand, and you walk them through to get them the right insurance, to get them insurance that will pay their bills and not leave them bankrupt. And I think that is one of the most important things of a patient navigator. Now, go on.
It says navigators are trained for the position and are often former nurses, social workers, or community health workers. Some are even cancer survivors themselves.
They're not Italian or Jewish mothers.
Yeah, the Jewish mother, that would be me. And they offer people with cancer and other diseases assistance with a wide range of services. Navigator programs began as a way to help patients originally who were poor and or underinsured or had low literacy skills. As the healthcare system has become more complex, these programs have expanded. You can find patient navigators in a variety of places in the community.
Most patient navigators, I would say, and you can tell me if I'm right or wrong, are mostly in large institutions, like a Baylor healthcare system or a THR healthcare system or an MD Anderson healthcare system. I think our practice is extremely rare